Service Excellence in Communications at Nadeau Medical Center. And I want to thank the university for allowing us to use their facility today. Welcome to our Ebola 101 class. I also want to thank Randy Morneault from the Nadeau High School, who's videotaping the program for us today. We have our speakers today are Dr. Michael Sullivan, Chief Medical Officer and Emergency Room Physician from Northern Maine Medical Center, and Alain Bois, to his left, Director of Nursing at Northern Maine Medical Center.
Thanks, Jen. Hello. So this is supposed to be an educational and open forum, so I encourage discussion, questions. Please feel free to interrupt. The audience is a little bit mixed, so I see what looks like students and a mixed population. So this is not a biology lecture, although if you have a medical question, I'm happy to answer it. It's more of a basic education, and it's this is based on a talk that Dr. St. Pierre, our emergency room director, developed for our staff at Northern Maine Medical Center. So we will skirt through some of the medical things that I don't think are pertinent to you, but please feel free to ask any questions, and this is really supposed to be informational, so please feel free to interrupt at any time. And for disclaimers, neither Alain or I didn't ask you, you're not receiving any compensation or from a drug company or anything, and nor am I, so we don't have any financial interests. And the content for this lecture I'm obtaining from Dr. St. Pierre, and this cannot be copyrighted or reproduced for any, I don't think for anything technically, but I think you can get his permission to do so, but you'd have to ask him. So. Those disclaimers out of the way, and that's who we are. So first thing is, what's a virus? Ebola is a virus, and as you can see, sorry, I should have checked to see if this thing worked, which it doesn't. There we go. Okay, so this is an animal cell, like in our own human body. A bacteria, and this is the size in microns. So a bacteria, which is like strep or something like that, would be this size, and a virus is, hundreds of times smaller than that. I don't like the way that they made this look like a spider. You can't see this. You can only see this with an electron microscope. But the purpose of this is to show that it's a bunch of either RNA or DNA in a protein capsule. So it's extremely small. But most importantly is that these are not living organisms. They cannot survive on their own. They need a host in order to survive, and that's key because a bacteria can survive on its own in soil or other areas, but a virus needs to have a host organism, and that's one of the mistakes that Ebola makes in terms of how quickly it kills its host, because it doesn't give a lot of time for it to replicate before it kills its host. So it's not a great virus for producing large-scale worldwide epidemics. I'm going to skip this one. Basically, what it talks about, basically what it is a virus is a piece of RNA or DNA, and it's in some type of coating. And it could be either an enveloped coating or non-enveloped, and it's really beyond the scope of this talk on what the difference between those two are. Except to say that an enveloped virus is much easier to kill because this outer membrane are very sensitive to anything. Heat, cold, basic cleaning agents and things like that. And Ebola is an enveloped virus, and so it's much easier to kill than non-enveloped viruses. So I think that's why I put this slide in here to show that. This is a great biology slide. Basically it shows how viruses work. And so here you have a virus, the piece of, for Ebola it's some RNA. It's got this protein coat. It binds to a cell membrane. In humans it's usually a macrophage is the first cells I think that usually get infected. And so it binds to a receptor, it's enveloped in, and then it gets in and it releases. And then once it's in, it gets into your own individual cells that make proteins. You have mitochondria and RNA that make proteins for your body, for all your cellular functions. And what it does is it hijacks those mechanisms within your cell to replicate itself. And then when it's done hijacking and replicating, it forms new viral coats, and then it releases itself. And that's how the Ebola virus replicates, and that's how most viruses work. An RNA virus gets in and produces protein. A DNA virus can replicate individually. Specifically for Ebola, I think you've all seen these pictures, what it looks like. It's a little piece of RNA, a bunch of proteins, and a spaghetti-looking cell that's really not a cell, membrane. The reason that Ebola is so dangerous and has such a high mortality rate is that it binds to cells in the immune system, mainly macrophages, and it releases this cascade of inflammatory markers and effects that causes a rapid progression of the disease. So what happens is that, like when you have a cold or any type of illness where your immune system gets ramped up and you produce a fever and things like that, the Ebola virus does that, in a supercharged way, and which is bad in that in all of this inflammatory cascade, it tends to cause deterioration and bleeding and all sorts of other problems. But the good news is that one of the first things that usually happens is a fever because of these inflammatory markers. So it lets us know early on, before someone's infectious, that they're infected with the virus. I'm going to turn over to Elaine for some history of Ebola.
So, I know Ebola became, for a lot of us, we probably just heard it in the recent months, but Ebola is not something that's been new. Currently, there's 5 known types of Ebola. One of them is specific to primates and not humans. Right now, the one that we are seeing is the Zaire one, which has a 90% mortality rate. However, what we're finding, and we're going to talk about it later on in the United States, the mortality rate is a little bit less than that, and we'll explain the reasoning behind that later on. So, as I was saying, it appears to be new. However, the first time that we came in contact with Ebola was in 1976. For the World Health Organization, this is something they've been dealing with for close to 40 years. It first originated from the Democratic Republic of Congo in 1976 in a little village near the Ebola River, which is where it got its name, Ebola. Where we think it originated from is from fruit bats that are flying around out there and are infecting primates, and then those villages were killing the primates and using the meat to feed their families, and were often undercooking the meat and therefore not killing the viruses that was inside the primates. And we believe that's how this became known to the human and infected humans. So currently, we have 3 countries that have epidemics. So like I said, it's been, the first case was in 1976 when we noticed an epidemic in that little village. But this is definitely the biggest that we've ever had in history of Ebola since we've known it. So currently, there are 3 countries in Africa that have an epidemic, which is in Guinea, in Sierra Leone, and then in Liberia. Let me go back to the previous slide. I've been told by the university here that they have students that are from Africa, but the ones that are here are either from South Africa or from Cameroon, which is right there. And the whole epidemic is on the western piece of the African country. Or continent. So as you can tell, this is probably the distance of Maine to Florida. So they're not located close to that epidemic. So currently there's those 3 countries, and of course we have cases in the United States as well. Currently, as of November 2, which is the latest number that I saw yesterday, the World Health Organization is estimating over 13,000 individuals are infected currently with Ebola. They're actually thinking, those are confirmed cases or patients that have presenting with the symptoms. They estimate that there's probably closer to 15,000 worldwide. So far, we're over 4,900 deaths. So actually 4,960 deaths so far. In the United States, we're still just at 4 cases, 1 death. The 2 nurses in Texas, we'll share later on how we feel those nurses probably the reason why they got infected. The important thing that we want to share is that they got infected as they were caring for the individual that first came in from West Africa and developed the symptoms and seek treatments way later in his disease, towards the end of his disease, before his death, where the viral load is extremely high in his body. The nurses that took care of him at the beginning of his disease have not come out to be infected. And then the one physician that came out positive a couple of weeks ago in New York City, who had also returned from caring for patients in Western Africa. Just another slide again to show the countries that are infected by this. This is slides that were used during a presentation by the World Health Organization to the leaders of various developed countries, asking for their help. And I think it speaks volume to the reasons why we have to have people, health professionals, go into Africa in the areas that are underdeveloped and don't have the resources that they have to help combat these epidemics, whether it's Ebola or any future ones. So at the bottom here, we have a slide where they anticipate by next January, so January 2015, with intervention, they anticipate that worldwide we will hit about 25,000 cases with Ebola. So they think that that's what we're going to cap it there, with intervention, so with sending aid, with sending supplies, with sending medical staff to help them out. They are estimated that if we would have sent no assistance whatsoever, as you can tell, it says 1,400, but that has to be multiplied by 1,000. If we would have sent no assistance or provided no assistance at all, the experts are estimated that we would have had 1.4 million individuals worldwide infected with Ebola. So it's a big difference. 25,000 is still high enough, but I think that speaks volume as to the importance for sending healthcare workers to assist and supplies to assist the countries that are struggling with epidemics. This is a slide that Dr. St. Pierre had found about the air travel coming back from Africa. As you may be aware, the government has decided that all flights coming back from Africa are going to be directed to 5 international airports: JFK, Newark, one in Texas, one in Atlanta, and one in Chicago. So those are the 5 airports right now that the airplanes are being directed. They're estimating of screening, which it looks at looking at the patient, asking them questions if they've been in Western Africa in contact with individuals with Ebola, scanning for temperature, and asking them to do a bunch of forms and papers and things like that. 150 people daily that they are screening at this. However, as you can tell, a lot of the flights leaving from Nigeria are going to other areas of the country that then can come back through that. So there's a bunch going to Europe, from Spain to Italy to France to Germany to UK, and then flying back to the United States. So they're not necessarily coming straight from there to the United States. They might be going all over the place. So I think that's interesting to see, and they're estimating the amount of volume coming in the United States of being about 6,000 per week. I think that's an interesting slide to take a look at. This is an older slide. There is currently a separate outbreak in Congo. 38 cases on that slide. It's probably a little bit more than that, but it's really contained there. It's not an epidemic, and they believe it's a different strain. So it's a whole different outbreak. Of course, this is older, and we've got a lot more cases at this point between the 3 countries that I talked about earlier. These are states that are currently seeking CDC assistance with what they consider to be maybe potentially Ebola cases. So all the reds are those that are seeking assistance by CDC, and where are the 2 states really where we've had patients in Texas and in New York that have tested positive so far. But you can see that it's spread out throughout the country, and they're really trying to ask assistance and guidance from federal CDC at this point. What we have here, and you may have heard us in the media, we have been working at this for probably a month now, over 3 weeks, so probably close to 4 weeks at a month. And we've had our screening process in place since then. So this is one of the screening tools that we've used in our primary care physicians' offices and in the emergency room, where the first thing that we ask the patients as they report is, do they have the symptoms that we'll be talking in a minute? Fevers, chills, muscle aches, severe headaches, abdominal pain, diarrhea, vomiting, unexplained bleeding. And if they do, have they recently been in contact with someone with Ebola or traveled to Western Africa? So that's been our screening tool that we've had in place for over a month at this point within our organization. And with that, if they qualify for those, we automatically put in place our protocol of isolating the patient completely separate from any other patients and healthcare worker. So I'll pass it back to Dr. Sullivan to talk about how does Ebola spread.
So this is the main fear factor for Ebola. And I know you've probably heard it 1,000 times, but I'm going to repeat it probably 1,000 more in this lecture. Direct contact, body fluids, stool, vomit, blood, urine, saliva, semen, breast milk of a sick person with EB, with Ebola virus disease. In particular, if you culture the virus, the vomit and diarrhea are the two areas with the highest viral load. Those are thought to be the most infectious. And in Africa, it's the transmission to healthcare workers exposed to large volumes of this. At the end stages of the disease, people are putting out, I think on average, like 10 liters a day of fluid with a high viral load. And then most importantly for Africa right now is the transmission during the burial process, which I am not and have no knowledge of or expertise in, but it's the handling of the bodies and any funeral rituals, because these bodies are highly infectious because they still have large volumes of virus, and so the exposure to the dead bodies is thought to be another large area for transmission. But once again, direct contact. So you have to have direct contact with these fluids, and then they have to get into your system through a mucous membrane or a cut. So it's not on your skin or on your clothes or inhalation. It's direct, well, I guess it could be inhalation if you're standing right over a pile of vomit. But it has to be direct contact, and that's the real key. And so you're hearing a lot now about, is it become airborne? The answer to that is no. There is, in the 100+ years of virology and the study of virology, there's never been a case of a virus such as this that has changed from a non-airborne to airborne virus. And so that is, it's hogwash, and it's a fear-mongering thing about the virus. One of the reasons that Ebola virus will not become airborne is that when it infects, it doesn't infect the respiratory mucosa. So when you have, let's look at influenza or the common cold, for instance, you get exposed to that by someone who's not infectious, or I'm sorry, not even sick yet. So I could have the flu right now and be incubating it, not even know that I'm sick, and where it's incubating and it's in the back of my nasopharynx and in my throat and in my upper respiratory tract. That's where it's replicating. And it's forming all of these little teeny droplets that you saw in the first few slides. And then I cough, and I'm expelling thousands to millions of copies of that virus onto this surface, which influenza can survive on for several days. And then someone can, if anyone's within a radius of me and they inhale these droplets, they can get it. Or if you touch that surface that I just coughed on, and then touch your face or anything, you can contract it. Highly contagious, easy to transmit because it's replicating in the respiratory mucosa. That is 180 degrees different than Ebola. Ebola does not infect the respiratory mucosa. It affects macrophages, so in your immune system, cells in your immune system, by the cut that you got it in. It then tends to induce this immune response with fever, so you pretty much know that you're going to get sick with it. It then tends to go to the liver, the next place where you're not going to be infecting anyone if your liver's infected. And then from the liver, it spreads to other organs. And one of the main places it spreads to is to the cells that line your blood vessels, and infects those cells, kills those cells, and that's what causes the bleeding. So it takes a long time from the time that you're exposed to it and you become infected with it to when you start to transmit it. And you're transmitting it in those fluids. Vomiting, later in the disease. Diarrhea, later in the disease. Bleeding, very late in the disease. So that's why that's why this is an easy disease to contain, is that first cells it's in are these macrophages. You release these cytokines which cause fever. Okay, now we know that this person is sick and they're potentially going to come down with Ebola. You then have several days from that time to when that person is infectious. So is that clear to everyone about how it's spread? And I think that's really the take-home message about it's not on surfaces, it's not in the air, and you can't get it from touching with your skin unless you have open sores and direct contact with a high viral load exposure. Incubation period from the time that you get exposed to the time you'll contract Ebola, 2 to 21 days. You see this huge range in fatality. The Zaire previously was around 90%, and now we're about 55%. I actually expect that number to go down as we have more and more, if our medical response improves, because with supportive care you can really lower that number. From the time you get symptoms to you're dead is 7 days. So it's a nasty bug once you get infected with it, and it takes about 2 weeks to recover. And several weeks it can survive in semen. I'm not sure about breast milk and other bodily fluids, but you can be infectious for several weeks, even though after you think you're recovered from the virus. From the time that you get exposed till you get sick, the peak is at 5 days, and as you can see, it drops down almost exponentially from that standpoint. So 90+% are going to occur after the first 2 weeks of exposure. So even though we quarantine people for 21 days or monitor them for 21 days, the last week is less than 10% of the cases. I'll let Elaine do the signs and symptoms.
Here. So, as I said earlier, some of the first few symptoms that we're going to see, one of the first indicative one is a sudden onset of a fever. Intense weakness, muscle pain, headache, and sore throat. I'll go to the next slide because I kind of prefer the bullet points if you don't mind. So, a fever, severe headache, muscle pain, and weakness. If we stop at those 4 first symptoms, what other disease can you think of, condition that represents with the same type of symptoms? The flu, right? And we're just starting our flu season. We actually had our first case last month in Lincoln County of the flu, positive flu. So that's why in the beginning the disease may be a little bit complicated to discern if is it the flu or is it the Ebola. And the only way to really test it is with a blood test, and Dr. Sullivan's going to be talking to that in the beginning. So again, when someone develops a fever in the beginning, and probably some severe headache and muscle pain, the viral load is just starting to build up inside of the body. So they're probably not as contagious, and they are not as contagious. And we know this from field experience in Africa, from years of dealing with that disease out there, and by blood test also. In the beginning, the marker that we use, the blood test that we use, the tests come out negative because the viral load is not to such point where it shows it. Later on, it develops with diarrhea, with vomiting, with some abdominal pain, some unexplained hemorrhaging, so bleeding or bruising. And the symptoms usually appear anywhere between 2 to 21 days, with the peak being at about 8 to 10, 12 days is what we seem to know at this point. The recovery from Ebola depends on the good supportive care. We'll be talking about that. What we mean about supportive care is IV fluids, taking care of the temperature with maybe Tylenol, with some medication, taking care of the nausea, rehydrating people. So people who recover from the Ebola infection develops antibodies that last for at least 10 years. And we're going to be talking about some of the little research, and you may have heard already about some of it in the media. Here's another slide that kind of explain the timeline of the symptoms and the signs. So between day 7 and 9, the first symptoms that are here are headache, fatigue, fever, muscle soreness. Day 10, sudden onset of high fever. So you could start vomiting, some blood passing, passive behaviors. Day 11, bruising starts. There can be starting to have some brain damage, bleeding from the nose, mouth, eyes, anus. And then eventually by the final stages, there's loss of consciousness. There could be seizures, massive internal bleeding, and eventually it could lead to death. Again, only one case in the United States so far. So lab testing, just all in.
So the current, I'm going to skip these. These are supportive tests that we do here. I'm going to skip that too. No? I guess I don't have the slide on the different tests. So these tests here, so when someone presents with Ebola, or symptoms consistent with Ebola, the first thing is to do, in these slides that Eric was showing, was to rule out other causes. So we're looking for other signs of infection, bacterial infection, malaria, typhoid, things like that. The test that we're currently using in the United States is a reverse PCR test. It's done in, I believe there's only 8 labs now that are doing it. Ours is in Boston. And what it is the test that takes that the blood from the potentially infected person, puts it in a little incubator with a chemical, an enzyme that tries to, well, it's called reverse transcriptase, and what it does is it tries to take that RNA, make copies of it, and make enough copies of it in order to detect it. And that's how we're currently detecting. The problem is that early on in the disease, there's not enough virus that you can actually replicate it, so the tests tend to come out negative. And that's currently the best, fastest test we have, but that can take 2 to 5 days from the time of exposure and or onset of symptoms to becoming positive. So you can have someone that's actually has Ebola that does not test positive for several days. It can take a couple of days to get that test back, because it's not magic, it's not a simple blood test that you do. You have to actually go through a huge process to do it. So there's only a few labs that are doing it. And that's part of the problem, is that you can't, it's not a simple blood test where you can, done at any hospital. It has to be sent to special facilities and under special handling and be done. Treatment. Yeah.
Would you incubate that person for the 2 to 5 days?
You mean isolate them?
Yes.
So assuming that they're symptomatic, and that's why you're doing the test, absolutely. They're on isolation precautions. So if someone presents with fever, and they have a travel history and a history that would be consistent with Ebola virus disease, you would treat them as an Ebola virus disease patient waiting for the test to come back. And you'd probably wait, even if the first test was negative, if it's looking like Ebola, you would continue the isolation until you have a couple of negative tests, or you're outside of that 1-week period where you would test to make sure that the reverse PCR is negative, they haven't generated antibodies to Ebola, so you would treat them as an Ebola patient until you're definitively sure that they're not. And the test is not, one negative test would not do that for you. Question? So we'll talk about some of the experimental treatments. There's really no treatment for Ebola. The real treatment is supportive care. IV fluids, if they're hemorrhaging, blood transfusions. Sometimes you get secondary infections. You can use antibiotics. Making sure that you're not missing something else, malaria, typhoid fever, other things that can present similarly. And then in the United States, we've been transferring patients, most patients, I don't think the New York patient was transferred to a specialized center where they have some of the other treatments available. And I think I'll go to the next slide. So this is the one everyone's heard about, ZMapp. And what it basically is an antibody, and it binds to the virus and prevents it from infecting your cells. And that's been proven to be effective. So they take monkeys that are exposed to Ebola virus that have been giving ZMapp, and it prevents infection. So it's been proven to work in monkeys, never been tested in humans, and we're now using it. 7 people have received it for compassionate use. Unfortunately, we have no controls, so we don't know if it works or not, but we do know it worked in monkeys, so we are using it mainly now to assess for safety. And then there's a couple of antiviral drugs that are actually further down. One is in phase 3 trials to basically stop the replication of the virus, but these things are all experimental. And I think there's actually 3 vaccines that are or maybe there's only 2 that are being, this may be the NIH one, that is been shown to work in primates, but they're just doing phase 1, just starting with human trials now for safety. We don't know anything for efficacy yet. But I'm confident there will be a vaccine for Ebola, but it's not going to be any time to combat this current outbreak. This outbreak should be over before any of these drugs or vaccines reach the phase where we're using them on a regular basis. Most important thing is prevention, and and this is why there's so much excitement in the media and the state and federal CDCs is early isolation of patients to prevent the transmission of the disease. Monitoring of patients, this is critical, so that if someone does come down with it after they've come back from an endemic area or they come in contact with someone, that you can then trace their steps to try to control the contacts of people that they've been exposed to. And this is pretty easy with Ebola because we know that it's direct contact with people that occurred during the symptomatic phase. It's not someone that you flew on an airplane with over from Africa. It's someone that you were living in a home with the day that you came down with a fever and you were vomiting. Those are the contacts we're worried about, not the people that you were with the week before. So it's pretty easy to trace that. Safe burials, there's a lot of effort in that right now on the handling of dead bodies to make sure that they're not infecting people that are caring for them. And then the healthcare worker protection is critical. So, you want to do this?
Sure.
This is Alliance's area of expertise.
So the standard precautions and the key elements for that, the first thing is we do have a skin. And as long as your skin is not broken, the skin acts as a barrier for infection. It's one of the normal body defenses that we have. So of course, one of the first things is proper hand hygiene. So washing your hands frequently, same thing as we do it now with the flu when we educate yourself, just wash your hands on a regular basis. Wearing gloves, wearing gowns that are water resistant so that the body fluids don't come over you. Having facial protection, eye, nose, and mouth. If they vomit, if they have projectile vomiting and that splashes, it's to protect the staff on that. Respiratory hygiene and cough etiquette. Cough etiquette, we usually recommend people cough in their elbow, not so much on their hands, then you cough on their hands and then you go shake someone's hand, didn't get a chance to wash your hands. Having proper environmental cleaning and disinfection. We've done that with our housekeeping staff. They receive additional training on this. Patient care equipment goes with that. Having proper waste disposal. At this point, the recommendation is to take the waste from Ebola patients and have it transported all the way to Rhode Island where it is burned. Injection safety and prevention of sharp injuries with our staff. And of course, the whole gearing up with the equipment. On your left-hand side, you have equipment similar to what we're using at the hospital, different colors, but it's the full hazmat suits, and the CDC has updated their protocols about 2 weeks ago, 2.5 weeks ago. Prior to that was more to what you have on your right. Nothing wrong with the one on the right either, except that there are some skin being exposed, and they think that maybe with some of the nurses that were caring from them, some of the things that I've heard is they may have broken protocol and gotten themselves infected and not realizing it during that time. But the equipment on the right-hand side, for this disease, you don't have to have the full powered air purifier system that we usually utilize with the hazmat suits. But the reason why we're using it is because that's the type C suits are the one that really covers the whole body and doesn't show any skin whatsoever. So currently, that's what we've been training our staff at the hospital is on the one on the left-hand side. So managing the exposure to the disease.
Okay.
Yeah.
You spoke of waste disposal. How long does the virus survive in the waste outside of the body, outside of its host?
I've seen anything from 3 to 6 hours.
It's low, less than a day.
Less than a day.
So sending it all the way to Rhode Island, it might be all gone before it gets there.
Well, I think in some of the bodily fluid, and I think Dr. Sullivan made reference to that, there are some that stays a little bit longer in the body. It's more alive in the body, like semen and maybe even breast milk. So I think that's why they want to be overcautious.
Oh, I'm not questioning that.
And so there's one company that I'm aware of that is certified in Maine to transport that biomedical waste, and that actually is the company that is assisting us up here with our biomedical waste.
Yes, so the 3 to 6 hours is on a surface or outside of the body with no support. But if you take a huge volume of stool or emesis and keep that in a decent temperature wrapped up, that may last longer. So it's a caution to do that. I wanted to go back to the gear. So we don't know for sure how the 2 nurses got infected, but this is a scary thing when you see people wearing these full hazmat suits and the respirators. There's absolutely no indication that any of this is necessary. And I think Elaine's point was the reason we use this is, one, everyone got scared, because the first case we have 2 healthcare workers infected. So everyone got scared, and they said, okay, well, we need to do full precaution. And the one benefit of this is that it covers the neck. My personal opinion is that this wasn't the problem. My personal opinion was that this was the problem. In Africa, they have big rubber boots, and when they step out of the treatment area, they step into a bucket of Clorox to kill off the virus, which kills it off. Whereas in the States, we don't wear rubber boots to work. We have little teeny cloth booty covers and over our tennis shoes and our exposed lower legs. And my best guess is that if that's the equipment that they were using, a standard gown with their scrubs and regular work shoes and these little booties, that this is most likely the area. So my gut tells me if we stuck to this, we would probably be fine. But nobody wants to take the chance, especially with 2 healthcare workers having been exposed. This is mainly for the hospital, what happens with healthcare workers that have been exposed, or anyone that's come in contact with, anyone who's come in contact with a patient that has had Ebola virus disease should be monitored for 21 days. And that's the big controversy now, is how should they be monitored? At home, can they go to work, who can they be exposed to, things like that. But that's the $1 million question. So take-homes, this was prepared before we had a healthcare worker return to Fort Kent, but still the likelihood is very low. If you use personal protective equipment as a healthcare worker and there's no break-in protocol, there's no exposure, you're not in a highly endemic area where you're likely to be contacted from somewhere else, the likelihood of having a case is extremely low. Ebola is not that contagious. It's hard to transmit. We have thousands of infections that are much easier to transmit than Ebola. Don't forget direct contact bodily fluids. Theoretically 0 risk with the use of proper protective equipment for healthcare workers. And this is really more of a healthcare related stuff. And this is mainly for hospital stuff. And that's also hospital related stuff as well. So I don't have anything I want to comment on that there. So I guess for me the take home for education is you're not infectious until you're symptomatic, and once you become symptomatic, you have several days before you're highly contagious, and that the stages where people with Ebola are highly contagious, where there's any respiratory or transmission of the virus, is late on in the disease. So by the time that the lung is invaded and you're coughing up blood, you will not be out in public. You'll be on a deathbed or hopefully in a hospital being cared for, preventing you from going to your deathbed, and you will be protected. So the public has 0 risk of contracting the disease unless there's an outbreak of Ebola, which there is not. We have 4 cases. That's not an outbreak in the United States. So there's no public risk, and healthcare risk is close to 0 as long as we're using appropriate personal protective equipment. So to me, that's the real take-home for this. So, does you have anything to add, Elaine?
And the last thing is just that our decisions need to be guided by science and not emotion. I think having an epidemic of fear can be just as detrimental to having a real epidemic of a disease. So I think educating ourselves and understanding the disease and how it lives, if I want to, or how it can spread, and utilizing science to make decision, I think is the better way to go about this. At this point, I guess we open it for questions.
Yeah.
I'm just curious with when you mentioned the 50% survival versus mortality.
Yeah.
All things being equal, same, two people, same treatment,
Yeah.
or say a group of 10,
Yeah.
50% pass away, 50% make it. Are there any common denominators in those two specific groups?
Yeah, so it's not the same treatment. That's the real key. So in the United States, we have a 75% success rate for treatment, and the only person that has died here is someone that was misdiagnosed when they presented. So this gentleman presented to the hospital with diarrhea, bleeding, and was sent home. They thought it was I don't know what they thought it was. They treated him with antibiotics and sent him home. And it was 2 days later, so he was at the end stage when he made it back to the hospital again. So that's the only death we've had. The other three that we have treated, they caught earlier in the disease, have all recovered.
But even like say in Africa where it's being treated, is there any common denominator between those who are surviving and those who don't make it?
The people, I think early treatment is the real key, so presenting earlier on in the disease. And to my knowledge, they're not using any of the experimental drugs, so there's really no trials there. So with any other bad disease, so once you get this, it's a bad disease. Younger people, healthier people, no comorbidities, those are the type of people that are going to probably do better. And then it's a rapidly progressive disease, so depending on, it's really the hemorrhaging, I think, that kills people. So if you're unlucky enough to have a major bleeding episode, you're done. But if you're fortunate enough to not have a major bleeding episode, you're probably going to survive. So I don't know if, I don't think it has to do with any specific treatment, but the supportive care has been shown to significantly decrease and that's why the Zaire prior to this outbreak had a 90% mortality. And in this outbreak in Africa, it has a 50% mortality. So, the virus has not changed. It's just that we have a more mobilized effort at the supportive care to help people from becoming just simple dehydrated, electrolytes being off, and dying from just simple preventable aspects of the disease. Yeah.
For the healthcare workers that were affected out in the United States, did they use the experimental drug?
I think that they were transferred to Emory.
Yeah,
so
to Maryland.
Yeah, Emory or Maryland?
I thought it was Maryland.
Yeah. So I think they did, but do you know?
No, I do not know.
Yeah, my suspicion is they did, just because they've been mobilizing to try to experiment with that. So I would think that healthcare workers were, and the other one that they brought back, the two healthcare workers that they brought back, they both used it on. So I'm assuming that they're using it, but I don't know. Yeah.
And does the hospital anticipate any sort of like a rush panic of people to the hospital during the flu season when it's at its fullest, with people thinking that they have Ebola? And if so, do you think that this year is a better year for people to get a flu shot so that they don't have to be concerned about that when they,
Yeah.
you know?
Yeah, good questions. So I don't like to use the word rush panic, but we definitely anticipate people coming in with concerns. With fevers, muscle aches, diarrhea, things like that. So we definitely anticipate that. And absolutely, that's why if you, every time you see a talk or someone talking about this, they say, get your flu shot, get your flu shot. And one of the reasons is, just like Elaine said, is that early on in the disease, it's almost identical symptoms. And so this will prevent the big aspect of fear. Because if we get a flu epidemic, which like we did a few years ago, then it's going to be, and we concurrently have cases of Ebola in the United States. It's going to be a nightmare. So that's why we're strongly encouraging people to get their flu shots. And I guess the one, the positive, if you can look at a positive aspect of this epidemic from my standpoint as a healthcare provider, is that even though this is not an airborne disease, what this has done is it's mobilized us and forced us to look at our healthcare system and network and processes for dealing with a potential airborne disease. And so if there became something like this in the future, which there will be something like this, this has been a major educational process for the United States. And fortunately, it was not in the midst of an epidemic. So it's great that the planning, preparedness, training is occurring with something that is so easy to contain with our current system. So did I answer your question? Okay. Any questions?
Are you still hearing from people canceling appointments up at the hospital or out of concern, or is that sort of slowed down?
Yeah, we haven't heard much. I have not anyway heard much, and in the areas that I oversee, I have not received notification that any have since last week.
I think the education has been helpful for people understanding that there's no risk, and I think it's been helpful with the university as well in terms of people that are in contact with someone that's had exposure to Ebola is not potentially contagious, and I think that message is starting to get out, and that's one of the reasons we want to do this, is making sure that people understand that you're not at risk being in public or being in the same room with someone. So the current guidelines from the CDC, the federal CDC, are that if you have someone that has been in a high-risk situation with exposure within the last 21 days, that is maintain a 3-foot distance. And that's even overcautious, because you're not, that person is not infectious, but you can be in the same room, same area, same location as someone, and you're not going to contract the disease, even if they're at the early stages of the disease. That's the real point. And people that are at high risk, that have had an exposure, had a break in their PPE, or any type of symptoms whatsoever, like you had a low-grade temperature, things like that, those people are being isolated. So they're not putting anyone at risk. Any more questions? All right, well, thank you all for coming, and we're available if you have any other questions.